would like to remind ourselves that when we are done, there's a opportunity for us to be able to share what we want to share. So if you would like to ask a question, kindly put up your hand. You use the raise hand button, and then you can ask whatever questions that you have to ask. Aside that, also you can type in your comments as earlier mentioned. Good. So this evening we have in the person of Madame Louisa Na, the K is the one that I have forgotten. Pardon me for that. Owusu. And she is okay, so she is a physiotherapist who is going to be aiding us with our discussion. And she is a seasoned physiotherapist who also works with Mission Pediatrics, aside working with Princess Marie Louis Hospital. So for short, they like to say the PML. So that's where she also works too, aside consulting for Mission Pediatrics. She's going to help us with our topic for today on hypotonia. Ever wondered what it is? Do you know what hypotonia is? Have you been able to identify hypotonia, sorry. Is there something that we can do to support kids or infants who have this condition? That is what Madame Owusu is going to be explaining and helping us to learn. So yes, we are streaming live on our YouTube channel. So if anyone can join the link, please tell them to use our Parent Roundtable link, and then they would be able to have access to it. So I like to call her Lulu. Lulu, are you ready for us this evening?
Yes, Ida.
Yay! So Lulu is ready for us, and we are going to set the ball rolling. So, audience, please, your speaker, Madame Louisa Owusu. Lulu, we are ready for you.
Okay. A minute, please.
Yes, ma'am. Yay, we get to see Lulu. So we get to see Lulu's slides. And as a reminder, please tell a friend to tell a friend, because yes, this is not our number. We hit more than this. So tell somebody that it is time. And Lulu, you have our attention, please.
Okay, a minute, please, Ida.
Yes, please. So as Lulu gets ready for us, I'll repeat it. If you have any questions as she explains things, kindly type it in the chat box. If so you don't forget, if you can also raise your hand or comment after her presentation, that would also be good. Please, you have our attention.
Okay. Thank you very much, Ida. Good evening to all our cherished listeners. My name is Louisa Nakrokai-Owusu, and I'm presenting on hypotonia in infants. Please, I hope you can see my screen. Ida, is my screen visible?
Yes, it's visible.
Okay, thank you.
Louisa, can we assist in any way?
Lulu, if you were, thank
Is it
you.
showing now?
Yes, it is showing. And we can hear you too.
Okay. Okay. Yes. So this is the outline of my presentation. We are going to look at what a muscle is, types of muscles, muscle tone, how muscles function, hypotonia, what is hypotonia, clinical features of hypotonia, problems related to hypotonia, the importance of therapy, our treatment, and then conclusion. So by way of introduction, movement is life, and this is initiated by muscles of the body. If you cease to move, then you cease to live. So once you are moving, then you are alive. And for us to be able to exhibit movement in our body, it requires the use of our muscles. And this movement requires coordination of our muscles. Muscles don't work in isolation, they work in pairs. So, and also in groups. So one has to do some activity, the other also will have to complement it. Then we are able to exhibit or elicit any movement that we want to. For humans, movement commences from the womb. So right in the womb, the baby begins to move the limbs, and the mother can feel that the baby is kicking till the time is due and the baby is brought out of the womb into the world. So babies are born exhibiting physiological pattern of movement or flexion in their limbs. So every child is born as they are positioned in the womb. So you have the upper limbs and the lower limbs in some form of flexion and basically midline function. So the baby is born and immediately you can see the baby sucking the thumb and able to latch onto the breast and then suck from the mother's breast. They are able to do all these because of that physiological flexion that they are born with and the midline activity that they present with. So this physiological flexion, it provides the basis for motor function as well as the physical development of the child. So for the child to be able to hold the neck up, maybe roll, creep, crawl, sit, transfer, stand, and walk. It all requires some form of flexion. Without any flexion at all, the child will not be able to elicit any movement or motor function. So development of postural control requires muscle tone, practice, and repetition. So for every child, for the child to be able to hold their head up against gravity or hold the trunk up, it requires that there should be some tone in the muscles. The muscles should not be flaccid or should not be rigid, but it should be a normal tone. And children also learn to exhibit this postural control through repetition. So for a child to master an activity, the baby is going to do that activity several times. If a child wants to hold the neck up, it's going to turn the head to the left, to the right, raise it up, bring it down several times before he's able to master the way to hold the neck up in an upright position. And all these require gravity, sound, and light. So whether the child is born blind, whether the child is born deaf, God in his own wisdom has made it possible for every child to be able to move due to gravity and other factors. So physical development influences how a child perceives information or sensory information around the environment, and also the visual motor development and vice versa. So for the child to look at an object and reach out for it, it assists in the child's physical development. The same way as the child develops and grows in age, he's able to see through a wider range of motion and reach out for objects that are far and wide compared to when it was closer to him. So all these the child does using perception and then the motor development. So children communicate through movements and gestures prior to speech development. So before a child learns to talk, the child is going to point to an object. If the child is hungry, maybe the baby is hungry, the mother will realize that the baby is sucking the thumb and making some sound and know that my baby is hungry, or the baby begins to cry. And if the baby is able to move, the baby may point to maybe a bottle or something. The mother will know that the baby wants food, or if he has even poo-pooed or something, he will make some gestures that will point to what he wants to be addressed for him. So prior to speech development, every child communicates to the mother or to the caregiver through movements and other forms of gestures. And emotional and social development affects how a child's move about. So for the child to be able to ascertain independence and then get off the mother, it all requires movement. If the mother wants to pick the child up and the child is lying, the child will raise the hands up that the mother should carry him or her. Now the child learns to creep, learns to crawl, learns to cruise along objects, learn to stand, walk, run about, and now play with his peers. So all of these developments requires that the child has to be mobile. So developing writing reaction enables the child to move out of discomfort or any injury. And when we talk about writing reactions, we are looking at automatic postural reflexes that enables the child's head to maintain an upright position and also the trunk to be in midline, even against gravity. So all of these require movement of the muscles. So what is a muscle? As we are talking about movement, we are saying that it is the muscles that enables us to move. A muscle is a soft tissue that comprises of specialized cells comprised into fibers. And they are basically responsible for contraction and relaxation to produce movement. So if I want to move my hand, some muscles are going to contract, others are going to relax for me to be able to exhibit that activity. And muscles work not in isolation, but in pairs or in groups. And we have what we call the agonists and the antagonists. The agonists are the ones, the group of muscles that contract and they shorten to produce force to elicit movement, whereas the antagonists, they relax and lengthen for movement to take place. So they allow for the movement to happen. So it's the agonist that initiates the movement, whereas the antagonist supports by allowing that movement to take place. If I want to move my hand like this, my biceps are going to contract. Those are my agonists for me to be able to lift my hand up. And then my triceps are going to relax. So they're going to lengthen for that movement to take place. Without the antagonist supporting the agonist, it becomes difficult for me to elicit any movement. The same way, without the agonist supporting the antagonist, there will not be any movement. So they work concurrently. And some muscles that exert sufficient force against gravity to pull us up. So as we are all moving about, gravity is weighing on us. So it's our muscles that generate force to counter what gravity brings upon us for us to be able to stand upright or maintain a good posture. And these muscles enable our postural reactions to maintain an upright posture and prevent us from injury. So for me to be able to move away from something that is going to harm me, I need to have these postural reactions in place. Otherwise, I will not be able to elicit that movement or even maintain an upright posture and run away from whatever perceived threat is coming after me. So we have various types of muscles. In the body, there are basically 3 types of muscles. These are the skeletal muscles, the smooth muscles, and the cardiac muscles. So the skeletal muscles, they are striated in appearance, and they are normally attached to the skeleton. So they are responsible for voluntary movements like postural control, balance, and stability. They are the only muscles that are responsible for voluntary movements in the body, and the only muscles that are extrinsic, sorry. And we also have the smooth muscles. These ones are found in the walls of our internal organs. So they're also striated in appearance, but they contract involuntarily, not on their own. So they contract involuntarily to allow substance to move in and out of our body organs. And when we come to the cardiac muscle, as the name suggests, this is found in the heart and is also striated in appearance and elicits involuntary movement. So it allows the heart to pump blood throughout all parts of the body. But for the purpose of this discussion, our focus is basically going to be on the skeletal muscles. So what is a muscle tone? We describe a muscle tone as resistance offered by muscles to a passive movement or continuous stretch. So if I want to move my hand up, I should have something that is going to resist me to move it up. But if I just move it up and I drop it down, it means there is no resistance at all. So what resists us from just dropping our hands down or controlling it even in space, it is what we call the muscle tone. And this facilitates muscular strength and motor activity. Without the required muscle tone, we will not have any motor function, and you are going to have weakness in our muscles as well. So for a normal tone, we describe it as a state of readiness. The moment I want to move my hand, I quickly just move it because everything is, the muscles are contracting very well. There is no tightness, there is no laxity anywhere, and there's no restriction at all. I'm able to just move it through any range of motion that I want to. So that's the state of readiness. So at complete rest, a muscle does not lose its tone. So when we all go to bed, you are lying down flat on your bed, but your muscles are still active. They may not be seen as contracting, but they don't lose their tone at all. They are just as ready to function anytime that you are ready to move any part of your body. And inactivation of any muscle can result in atrophy or weakness. So without the use of the muscle, you're going to have what we call wasting. And by the time you realize, that muscle becomes smaller and the child may even end up shrinking in size. So appropriate muscle tone enables the child to respond quickly to anything at all, either through balanced responses or writing reactions, or what we call writing reactions. And this is the automatic postural reflexes that a child elicits to maintain the head in a neutral position, and then the trunk also in alignment. So for the child to be able to maybe sit upright or get up from lying to sitting, it requires an appropriate muscle tone. Anything short of that, it makes it difficult for the child to elicit that movement. And it also allows the child's muscles to quickly relax once the perceived threat is gone. So without any danger, the muscles can automatically relax on their own. There are two main components when it comes to muscle tone. This we refer to as the phasic tone and then the postural tone. Now, the phasic tone is the passive resistance to movement of the appendicular structures or the joint extremities. So these are basically responsible for locomotion or movement. So like if I want to walk, I want to jump, I want to run, I'm going to use my lower limbs and my upper limbs. Likewise, if I want to move my hand to grab something, I'm going to use my hand. So this phasic tone is what is present in our pectoral girdle, pelvic girdle, and then our upper limbs and lower limbs. But when it comes to the postural tone, it is the resistance to passive movement of the axial structures, so the axial muscles. So the muscles around the skull, connected to the neck, the back, the trunk. And they are basically responsible for posture and body alignment, and they are gravity dependent. Unlike the phasic tone, which cannot be solely dependent on gravity, when it comes to the postural tone, they depend solely on gravity. So for the child to sit, for the child to crawl, for the child to walk, that child needs postural tone as well as phasic tone. So how do muscles function? For the muscle in our bodies to function, they require the best length for activation. So if a muscle is too short, it becomes difficult for that muscle to function appropriately. So let's say that my hand, I have an injury affecting my hand, and then all of a sudden my hand is shrinking in size. It becomes difficult for me to functionally use that hand because that length is affected, the length of the muscle is affected. So for full function of the muscle, it requires that it be at its best length. And muscles generate their effective force at mid-length. So when we look at those who build their muscles, like the Mr. Ghana and the rest, you look at their biceps, what we call macho, you see that it is all pumped up, actually at the middle part of their arm. That is where maximum force is generated. So when they are lifting, most of the force comes from there for them to be able to lift whatever weights that they want to lift. And muscles need to gain alignment. If they are not in alignment, it becomes difficult to function. If one is acting in opposition. Like I said, they work in pairs or in groups. So if one is not in alignment with the other, it becomes difficult for that muscle group to function. And they need sufficient activity to generate force for action. Something must stimulate a muscle to work. And sometimes it can be through partial or full weight bearing, or even through sensory stimulation. And also, muscles require appropriate posture or pattern to generate a force for action. So for the muscle to work, aside being in alignment, the posture is also very important. Otherwise, you don't have that muscles working effectively. You can have sometimes compensation rather taking place. So now we come to our topic. After talking about muscles and looking at what a muscle tone is, we come to hypotonia. What is hypotonia? Hypotonia can best be defined as decrease in muscle tone or floppiness with varying degrees of progression. We emphasize that varying degrees of progression because sometimes some muscles can be very floppy or decreased in tone, but it's not going to worsen over time. But in certain conditions, you have that how the child is presenting in that floppy state, it's becoming weaker and worsening over time. So hypotonia occurs in multiple neuromuscular, metabolic, and genetic disorders, and it can be a cardinal sign of global developmental delay. So like I said, if the muscle is not in alignment, the muscle is not able to generate enough activity, that child will not be able to exhibit any movement, and that child may be stunted in physical development. So a child with hypotonia has muscles that are slow to initiate contraction against any external force, and they cannot even sustain a muscle contraction for long. So that child's muscle fibers are not able to initiate any contraction, or even if they do, it is very, very minimal to generate an external force for that muscle to function effectively. So the force may be small, so it's not able to function at mid-length. It's not also maybe able to function in alignment, let alone maintain or sustain a contraction for long. So this, what we call hypotonia may also involve postural tone, like we said earlier, that's those has to do with the muscles around the skull, around the neck, the back, and the trunk. So in this case, it can also affect the child's sucking reflex, the child's ability to suck and swallowing abilities. So this is a picture of a hypotonic baby compared to a normal baby. You look at the head, look at how the head is aligned, and look at the floppy baby. The head is just down, and you can see how lax the muscles are when it comes to the upper limbs and the lower limbs. Unlike the normal baby, you see that physiological flexion that we spoke about in the introduction taking place in both upper limbs and lower limbs. So they're all positioned in the same hand, but how the child is controlling himself will let you know that this child is hypotonic or this child is not. So that's a picture of a floppy baby versus a normal baby. So what are the clinical features of hypotonia? The first sign that we normally see is a poor neck and trunk control. So the baby's head is always hanging. The mother will complain that if I have to carry the baby, I always have to support the baby with my hand around the neck, around the head. Otherwise, the neck is just going to drop. So the baby's head may not be that big, but the neck cannot hold the head in an upright posture. Likewise, the trunk. So the baby always require maximum support when handling or when carried about. And sometimes they also have what we call weak cry because the muscles are so floppy and they are not able to even sustain a contraction or sometimes elicit any contraction at all. That child does not even have the ability to cry out loud. So you may have some form of shallow crying or weak cry. That's if the mother or the caregiver is not careful, you're not close to the baby. The baby may be crying, but you not even hear that the baby is crying because there is no much force to generate any sound that would be so loud to be audible. And they also have what we call little or no movement at all. Some hypotonic babies can elicit some movement, but it is not much. Some too are not able to elicit any movement at all. So if you put the child in supine, by the time you come back, the child is still in supine, not moving, or try to even move to the side, and that is all that the child may be able to do. Sometimes you put the baby in prone, and some of the mothers will complain that the baby is not even able to breathe at all. Like he has difficulty breathing. And if you're not careful, you can even bury the nose in the cloth or the bed sheet. So you're not able to elicit any movement or little movement. And the head lag, when pulled into sitting position, at least from 2 to 3 months old, we expect that when you pull a baby up into sitting from supine, that baby should hold the neck up at least at an acute angle of probably about 30 to 60 degrees before pulling up, even though the child may not be able to have attained full neck control. But when it comes to the hypotonic babies, trying to put them into sitting, you see the head lag so much severe. And even after 3 months of age, you still see that when you're pulling that baby into sitting, the head is just hanging posteriorly. And they also have no resistance to passive movement of the limbs. If you just move the upper limb, it goes through full range of motion. There's no resistance, there's no restriction, there's no difficulty at all. And sometimes they also have what you call decreased sensation or reduced sensory intake. So they require a deep sensation, or their high their threshold is very high when it comes to sensory stimulation. And they also present in this frog-like posture. So you see that the upper limbs and the lower limbs, they are abducted. Then the knees are kind of like flexed, sometimes also extended, and they spread all over the surface of the bed. So if you put the baby in supine, the baby has taken a wide surface area of the bed, the same way in prone, because of that posture they assume. And they have excessive range of motion at the joints because of the ligaments are very lax and hypermobile joints. Their range of motion is usually very, very excessive. And they tend to have delayed motor development. So when it's time for the child to sit, maybe 6 to 9 months, the child to sit, the child may not be able to sit, let alone transfer, stand, crawl, stand, cruise, and walk independently. So this is a sign of a floppy infant. So we see the C shape compared to the normal baby that we saw earlier on, how the limbs are just hanging and the head down like that. And then the head lag that we spoke about. Then you see that if you carry the baby even in the you support the baby around the axilla, it's kind of like slipping down in between your hands. So what are the problems related with hypotonia? It comes about with so many issues. First and foremost is little or no motor activity. Because the muscles are not able to elicit any contraction or maintain or sustain any contraction at all, sometimes there is little movement or no movement at all. So like I said, the mother will position the baby in supine or prone, and she'll come back after how many hours the baby is still in that position. And they also tend to have reduced sensory intake, in the sense that they require high threshold to sensory stimulation. So if any response to light touch, you will not get them to elicit any movement at all, but sometimes to deep touch, because they are usually immobile. And they also tend to have feeding difficulties. So like we said in the postural tone, because the muscles sometimes around the mouth may be very weak, they are not able to swallow solid food. So most of the times it's smoothie-like food or porridge-like food that they tend to take. And some of them too, they are not able to elicit what we call the cough or gag reflex. So in that case, feeding becomes difficult. And if care is not taken when feeding such babies, you can have them aspirating. They are mostly susceptible to aspiration and can lead to recurrent chest infection. So swallowing semi-solid food or solid foods becomes quite difficult for babies with hypotonia. And also to elicit gag reflex or cough reflex is also very, very difficult for them. So their feeding can be quite challenging. And if you don't balance it with maybe what the dietitian or the nutrition will give you, the child can end up being malnourished. And they also sometimes exhibit abnormal postural patterns. So you don't have the body being alignment. Maybe if you want the child to sit, you put the child in sitting, the child will just go forward, bend the head forward. You're not able to maintain the trunk in an upright posture. Likewise, if you want the child to maybe move the arms, he may try to lie on one particular side to be able to move one hand even through a little range of motion. So their patterns, their postural patterns are usually not upright and not appropriate. And they can also develop contractures and deformities. So for babies with hypotonia, because of the ligaments are very laxed and then the joints are hypermobile, without any therapy or any intervention, sometimes the muscles tend to shrink in size. Like we said, that inactivation of any muscle will result in atrophy or weakness. So as the child is growing in length, the bones are increasing in length. But what happens with contractures is that the muscles are not able to grow to align with the bone length. So you have shortening taking place. So the child not moving the body parts, the muscles now begin to shrink in size and shorten in length. And by the time you realize, they tend to pull the joints forward. And that's where contractures also take place. And sometimes you can have them also developing subluxation of the shoulder joints or some anterior dislocation of the hip joints, especially. Then they tend to have respiratory difficulties. When it comes to taking in air, they're able to take in air. The expiration can be okay, but even though it's not perfect. But when it comes to expiration, they are not able to expire the inhaled air that they have taken in. So there is not enough gaseous exchange. And you see that they're just drawing the air in, but the breathing pattern is very, very shallow. You may even see that diaphragmatic pattern of breathing where the abdomen is just like moving up and down. So their respiration normally is not that effective. And they can also develop spinal deformity, especially in the spine, whereby there's no control in the postural tone. Once the head moves to one particular direction, automatically the trunk is going to move towards that direction. So that child may now end up developing scoliosis. And if the baby is not well handled, sometimes even though the baby hasn't gained enough tone in the muscles, you can have the caregiver or the family putting the baby in a walker. So the baby will tend to move towards one side. And by the time you realize, that baby end up becoming scoliotic. So why should we have therapy for a baby or a child with hypotonia? The reason being that it reduces musculoskeletal impairment. So whereby the child may develop stiffness in the joints that may lead to pain that may not be bearable for the child. When you start with therapy, it reduces pain in the joints and also reduces stiffness or prevents stiffness even from taking place, as well as secondary impairments like contractures or deformities from happening. It also improves the quality of life for that child. So the child who was once lying down and couldn't move can now maybe sit upright and play with toys around him, or even join his or her peers in rolling on the floor or creeping or crawling about. It also helps to keep the airways patent, especially for those newborn on admission who probably may be on oxygen or CPAP. So when we start early intervention like that, they're able to now improve upon their oxygen intake and also breathe very well and promote wellness and fitness in the child. So the child is, with time, maybe may take quite some time, but able to now ascertain independence and optimal functioning. So what do we do for a baby or a child with hypotonia? As physios, a thorough assessment forms the foundation for our management. So every child presents differently. Kofi may present differently from AMA, even though they may all have hypotonia. And like I said, there may be varying degrees of progression when it comes to their floppiness. So it's during our assessments that we are able to know exactly what the child needs and the kind of intervention we should put in place for that child. And also, a child's first occupation is play. So everything is done through play. Through assessment is play. Through therapy, it is play. So we use audio-visual toys to offer stimulation to get the children to elicit some movement and also problem solving. And treatment is not planned in isolation, but with the family or with the caregiver, because the baby is with the child. And the baby, if you spend much time in therapy, maybe 1 hour, aside that, the entire time the baby spends with the family. So we involve the family or the caregiver so that they will know exactly what to do for the child at any point in time. And the home program is outlined for effective carryover, because if they're going to just rely on what we do for them at the clinic, it will not be enough, because this is a whole journey and it requires quite an effort to get that child to build tone in the muscles and function effectively. So when it comes to the treatment, we start with the neonates. When we talk about neonates, those that are less than a month old. So for the neonates, they are very, very critical, but that is the best time that we can have them to also improve very, very much, especially when they are even on admission. So whether they are the pediatric intensive care unit or the newborn care unit, positioning in bed is very, very important. Now, at an early stage like that, every baby or every child has the potential for change in their postural pattern or in their postural control. So positioning also enables the child to now start eliciting some movements that they are not able to, or it provides feedback to the brain for the child to know that I can function in this particular direction or in this way. And swaddling, by swaddling, we use the cloth. So just like how baby Jesus was wrapped in the manger, we use the cloth to wrap the baby with both upper limbs and lower limbs in flexion. And that builds up tone in the muscle. So for a baby who is all flaccid and the upper limbs and lower limbs are all extended, when you use the core sheets or any cloth through the swaddling, for the neonates, within some few days, you tend to see that their tone is now beginning to build up. Then we do what we call nesting. Nesting, we use a cloth to like mimic the womb. So we mold it in an oval shape. So depending on how the child is presenting, with sometimes in the intensive care unit, the child may have some tubes in place. So some positions may not be appropriate. Maybe because of the tube the baby have, you cannot swaddle the baby. But you can do nesting if it requires that the baby has to lie supine, whereby you use the cloth to mimic the womb. So the baby's upper limbs are all flexed and lower limbs are flexed. So if the baby wants to elicit any movement at all, that baby elicits that movement within the boundaries of the cloth that you have used to mimic the womb. Then proper handling in the sense how we carry the babies, whether in the ward or when they are discharged home. So when it comes to positioning, this how we can position them in sideline. Those are the newborn care units or at the pediatric intensive care units, or even if they have been discharged in their home, we teach the mothers to position them this way. So in sideline position, you can see that the arm is over the trunk or over the chest. This way, with time, the child will now be able to be prompted on how to put the hand in the mouth and then begin that sucking. And in this way also, you build up tone in the trunk as well as the limbs. So the limbs are not widely spaced apart like the frog-like posture they present with. So this position counters the position of the frog-like posture that babies with hypotonia present with. So in prone, you put them in prone like this, whereby you have that posterior pelvic tilt around the pelvic region. So then the knees are all bent forward like that. And then the toes are a little, the feet are extended. So in this position, that baby now will try to maybe move the limbs or even try to move the head. So if the baby has no other condition, we encourage the mothers that they should do more tummy time activities for babies with hypotonia. So this is the next thing that we talk about, whereby we use the core sheet or the cloth to mimic the womb, so in an oval shape, and that's how the limbs are positioned. So if the baby wants to elicit any movement at all, it's not going to go within an excessive range, but within the boundaries of the cloth. So we can do this even whilst on the ward, or even when the baby is discharged, to discuss with the family or the caregivers. Then there's the swaddling, whereby we cross both upper limbs and lower limbs, like I said, like baby Jesus lying in the manger. Then use the core sheet to wrap around the baby so that the limbs are all held in flexion. Then when it comes to the handling, we can hold them like this, even whilst on the ward, whereby the baby is lying on the mother's chest, or whether the PT or the nurse is carried like that for some few minutes. And therapy is done every day till the baby is discharged from the ward. So when we do it effectively, before the baby may be discharged from the ward, the baby's movements will be now much better, that we can continue on outpatient basis. So as the child grows, we can also do what we call hammock therapy. And this is basically like a sling, a cloth that is attached or hanged, and the baby can lie inside. By lying inside, you have both upper limbs and lower limbs going into flexion. So for those who cannot afford the hammock therapy, we teach them how to use maybe a cloth to mimic this hammock therapy. Then we facilitate rolling, because when it comes to babies with hypotonia, movement against gravity is their major challenge. So we start with exercises that are gravity eliminated. So something like weight bearing in prone, or facilitation of rolling. It also helps build their tone. And core strengthening exercises using the gym ball or the roller or any other device at all, as well as sitting balance training. So when it comes to sitting balance training, there are various ways we train the children on how to sit. Sometimes with the support of sandbags, or sometimes we get them to get some specialized chairs that can support the child in sitting, or with the aid of gaiters as well to assist in sitting, and the mother can prop up with pillows or cloth. Then weight bearing on all fours. In fact, weight bearing on all fours is very, very good for every child, because it helps them raise their neck up against gravity and also build their tone in the muscle tone in their trunk, and prepare them for transfers. So facilitation of transfers, like transfer from lying to sitting, ability to crawl, pull to stand, and then cruise against any supports. Then standing against posterior or anterior supports. So the child may be standing against the wall with the aid of a gaiter, or maybe holding on to a walker. If I talk about a walker, I'm not talking about the sitting walker, but the one that the children move about with. So holding on to that walker to stand with the aid of a pair of gaiters or back slap. Then ambulatory training, maybe using a parallel bar, or we train the mothers on how to also use some sticks to do this parallel bar at home. Then we come to balance and stability exercise. So it's not that when the child begins to walk, the child is discharged from therapy. We look at the child's balance and stability. Is the child able to carry out obstacle clearing activities? Like if the child is walking now and he meets any object in front of him or her, can that child topple over or just fall down or cross over that obstacle? Can that child climb and descend the staircase without any support? So these are some stability and balance exercises that we also ensure for the children. So when it comes, this example of what a hammock therapy is and it looks like. So you see how the baby's limbs are all flexed, hanging inside the cloth. And we also recommend, depending on the age of the child, the use of the rocker. The rocker, because of the sack that they lie inside, when you position the baby in this rocker, he tends to sag a little. So he's not lying flat on the back. And by so doing, able to flex both upper limbs and lower limbs. You can position with a cloth inside like that, so that that child is not lying all supine. But at some particular ages, the rocker may not be appropriate for the child. So in conclusion, physio plays a very good role when it comes to habitation and rehabilitation of children with hypotonia. through a combination of various handling techniques, exercise protocol, positioning, and some use of assistive devices like the ankle foot orthosis or the knee ankle foot orthosis or the gaiters, among other devices. Physio helps to restore optimal functioning and independence in the child. And early intervention and consistency yields better prognosis. So we recommend that babies are referred very early for therapy, and also they become consistent when it comes to therapy. That's when you're able to get them to function very well at their own independence. Thank you. Ida.
Yes. So the applause that we see, the virtual applauses that we see with the smiles of others helps us know that our audience have enjoyed everything that you've taught us this evening. Thank you so much, Lulu, for everything. Thank you. Thank you. Thank you. So now it's your turn as audience. I know Louisa was explaining a whole lot and helping us to understand what we can do to support the kids. What did you learn out of it? I would love people to share with me what they picked out of this webinar. Since currently I don't have any questions, but if anyone wants to ask any question, wants to contribute, you can put up your hand, or you can simply type it in the chat box. That is if you would want that also. So please tell me. If you don't have any question, comments, or anything, I have a question for the audience. What kind of support? Oh, okay. So Elizabeth wants to ask or comment before. So yes, Elizabeth, kindly unmute. You've been asked to unmute. I'm sorry, please unmute yourself.
Please, can you hear me?
Yes,
Yeah.
please.
Good evening. Thank you, Ida, and thank you, Louisa, too, for that wonderful presentation. This is my first time actually joining a physio presentation or lecture, and I'm glad Mission Pediatrics is the one giving me that. I'm grateful. And so, with the treatment, I'm curious. How long should it take for you to, if you want to do it by yourself at home, how long should it take for you to keep the child in such positions? And also, I've forgotten what I wanted to ask, but you can answer me on this. I think I'm good.
Definitely. When something else pops up, please just put up your hand and then, or you can share it at whichever point that you would want to share. Lulu,
Great.
oh,
Please let me
go
add
ahead.
up. So I think Louisa Louisa only mentioned on the neonate, which means with a very early infant. I'm asking and wondering if someone should have grown out of the developmental stage. What do we do? What treatments can we give to help that person out?
Okay, thank you, Lizzie, for that. Lulu,
Thank
the
you
voice
very
is
much,
hot.
Elizabeth, for that question. I will start with the last one. I talked about the neonate first before I moved to the older infants. So when I talked about the swaddling, the nesting, the positioning, and the proper handling, that had to do with the neonates. But talking about the sitting balance training, the rolling, then up to ambulatory training and balance and stability exercises, that has to do with the older infants. So I didn't just talk about the new needs. And when it comes to the positioning, like I said, every child is different. So depending on the assessments and then the goals we set with the parents or the caregivers, then we can come to a conclusion that maybe position this child in prone for about 10 to 15 minutes. And then let's see, but make sure that you are watching over the baby, you're not leaving the baby in that position. So there's no specific time depending on what we see in assessments, then we can recommend how long you can support your baby or your child in a particular position, if possible.
Okay, so there's no time limits with it, but then It depends on, as you mentioned, each child is different. So each child will determine what can be done to support as and when necessary. Thank you, Lulu. Okay, so what about you? If you don't have any questions, me, I want to find out what you gathered from it. What were some of the positions that Louisa talked about that you are personally taking in? I like the nestling one. Like that's, I don't know, sometimes I wish I were a baby. Okay, please, anyone else wants to share something with us? When the audience are like this, it makes me realize that they really have understood everything. As such, we don't need to stress. Let me take a look at what is happening on our YouTube channel. If there is any comment, question, or concern from there. Okay. All right. So Hetty is saying that well done, Louisa. And Elizabeth was also saying thanks for the clarity. You've explained it to her to get. Um Sofa says great presentation and she's grateful. And Ramatu also says that excellent presentation. Yay. Oh, Elizabeth, we are grateful that you also joined this webinar. Oh, we take all the balloons and the claps and everything. Yay. We thank you for joining too. When the audience are like this, and so what we would plead is that just as you've gotten to enjoy this today from us, this is not what we always do. We open up every time. Yes, we do this the fourth Sunday of every month. Um as the fourth Sunday, this particular one tends to be the end for the whole year that we have. Because unfortunately or fortunately, next month is our special education and inclusion webinar. As such, with that one, it's a paid for webinar where Godfred is going to show us our flyer and get to see. We have just 1 week more till the end of the registrations. But Faustina is saying that she has also learned a lot today. Oh, thank you, Faustina, for joining. You see why we always encourage you to join our webinars. Gilbert also on our YouTube channel says that he loves the presentation. Thank you, Gilbert, for joining on YouTube. We appreciate you for doing that. And so, as earlier mentioned, we have lots and lots of webinars available for you on our YouTube channel. You can have access to all that we've done for this year and previous years also. This year, the decision was for you to get to enjoy things from our various departments that we have in Mission Pediatrics. So you got to hear from the nurses corner, you got to hear from physio today. You've also heard from our behavior team, we've heard from our psychology, our psychiatry, and all these different divisions that we have in Mission. We do this because we want you to get to learn at no cost. As such, this is part of our CSR for you. We are always appreciative of the fact that you get to join us, and we thank you for doing that. We plead with you to keep helping others also get to learn as you've also learned from us today. As Mami says, Lulu, great job and thank you so much. When people get to understand, our audiences understand and they don't get to ask questions, I am happy because it tells me that my presenter was amazing. And as such, after thanking Lulu, I would also like to thank you. Okay, so I know Elizabeth is so happy today. She's still giving you claps. Go, Lulu. Ramato has a question in here. She says that please, may I know what some of the causes are and if there's any means of prevention?
Some of the causes for hypotonia.
Yes, please. And then if there's any means that anything that we can do to prevent it.
Oh, okay. Well, it can be from cerebral palsy. You can have a cerebral palsy child presenting with hypotonia. And I must say, when it comes to cerebral palsy, the causes are a lot. It could be from infection, from cerebral malaria, from neonatal jaundice, from asphyxia, and what have you. So what I would say is preventable is that the moment you notice any weakness in your baby, you seek early intervention. You can also have genetic disorders like Down syndrome, chromosomal disorders like Down syndrome, presenting with hypotonia. So the causes are quite varying, but what can be done for the child is once you notice any weakness in the baby, you seek for early intervention.
Mm. So as we always say in this space, early intervention is key. So you see something, please do not wait. Make sure you take the initiative to go look for help where the help can be given you. And Ramatu is thanking you for the explanation also. So as I said earlier, we have our special education and inclusion webinar happening next month. So next month from the 8th to the 30th, all weekends, not all weekends. So aside the first week, the second, third, fourth week, and fifth week, we would have our webinars in there. And so we are encouraging you, if you've not already registered and paid, please do so. So Sika says that, please, is there any way by which hypotonia can be detected in utero, sorry, by ultrasound scan?
No. No, please.
Unfortunately, we don't get to have that. Wow. Okay. So although we don't get to have that, we know that we've been given some means of support. So let's make sure that we do what we need to do. The very moment we realize the slightest muscle weakness, because what you may sleep on today may be detrimental to your ward. So early intervention is always key. Please, let's make sure that we give the kids the needed support at the right time to be able to assist them. And in the end, it also helps us personally. We thank you very much for joining this week, ending our session. However, in December, we have our family fun day out. Yes, our flyer is out there. And our family fun day out is going to be happening on the 13th of December. So please make a date with us. It is free entry, free. Please tell a friend to tell a friend and bring everyone, your parents, kids, everyone in the family. Come, have fun. Come join the bouncing castles and then the trampolines and all that, the dance and all that. Please come be a part of us. And yes, our flyers have been shared in the chat box. You can have a look at it. If you've not registered for the special education and inclusion webinar, so we are giving you one discount. Did you know that in joining the webinar, ideally you should currently be paying 500 cedis for enjoying all 8 sessions? But for today, I'm feeling generous. Kindly click on that link in there. And when you register today, instead of paying 500 for all the 8 sessions, you get to pay 300 for all the 8 sessions. At the discount code section, kindly put the roundtable, because that is the code for today. Roundtable, and pay your 300 cedis to the Momo number as indicated in there, because that is where we get to give you that offer. Because you are a part of our community, joining us for the first time, or even if it's not your first, please make use of this. Come and learn. Come and enjoy what we need to enjoy. And you share your experiences with us also. Yes, I do not have any more to say. Is there any other thing, Lulu, you'd like to share with us, please, before we go?
Oh, no, please.
Okay. So if Lulu has nothing to share with us, Godi, please, is there something else that I may have forgotten?
Oh, not. I think you've mentioned everything.
Okay. So Fortunately, if my people say I have mentioned everything, me, I want to say a big thank you to you for joining us, taking this time out of your schedule the whole day. I know some of you may be tired, some may be in transit, wherever you find yourself. Thank you for being a part of our program today. Thank you, Lulu, so much. Although
Welcome, my
it was quite short. We got to have an attendance of people wanting to listen and learn. And yes, it's on YouTube. You all can go and enjoy it later also. Thank you for being a part. And from the team at Mission Pediatrics, we say Yedamwase. Have a good evening and enjoy
Good
your week.
night.
Good night, everyone.
Good night.